uh, Dr. S.K. Sikdar sir has been an epitome of both mental health, family welfare. I have been working as state family welfare officer with him for last so many years. Sir has national. Sir is going to be giving a national as well as international perspective vis-a-vis the same. I request S.K. Sikdar sir. He has a small presentation, a 5 to 6 minute presentation, where he is going to deliberate upon the national as well as the state scenario. Please run the presentation.
Thank you very much, Harun. It's really a pleasure to be here and make this very small presentation. I thought the presentation is necessary for the sake of setting the context for this particular panel that we have. We have talked about maternal health, child health throughout the morning, and the impressive results that has come out of Jammu Kashmir is something very, very laudable, and we really congratulate the state on the way that it is going ahead. But having said so, there are issues which is there in every state of India, and Jammu Kashmir is no exception, that how do we really take the services to the last mile, and that is one area where Jammu and Kashmir has to really come up trumps. Otherwise, what happens is that that particular sort of disaggregation that you see in the data in different districts of the country, in the state. For example, your state has around 20 districts, and if I see your performances in the districts, most of the districts do not really have a viable private sector, barring few districts. So maybe 4 to 6 districts in one region, another 4 to 6 districts in another region. They are the districts where the majority of the services are being provided, and that's the hard reality. And in that context, the MCH center, what your mission director mentioned about in Lameri, or Lamberi to be precise, is one area which was catering to some population, huge number of population who had to trek or rather commute 7 to 10 hours to reach the next facility, where the chances of maternal mortality on transit would have been very high. We're just waiting for you to take that particular initiative forward, say in the next 1 to 2 years, so that you can come up with a facility which can really deliver the goods. Coming to the specific slides that I want to show you is on the Caesarean sections, Boon and Bane. Can we have the slides, please? Are you sharing? Okay, fine. It's all right. It's all right. So if you see we say what are the area. I mean, either it's a Boon or a Bane. All of us know about it. And here, if you see, if it is medically justified, definitely go ahead for this one. Because C-section effectively reduces the maternal and parental mortality and also the morbidity. And then also, in the settings, underuse is one other area where probably we have a plethora of gynecologists and you are not able to provide, you are not providing the services. That also happens in many districts of our state. So underuse is one area where we really can take advantage of it. Moreover, a C-section is not a standalone event. All of us know about it, or an adverse event. It's something what is that is being either medically indicated, or sometimes, or rather many a times nowadays, it becomes elective. Also, reducing the frequency of the C-sections to a less than a safe threshold value. That is something what we are looking at over here, but it should not be replacing it with poor instrumentation delivery. Because if the instrumentation delivery is poor, then what happens is the whole very purpose of C-section gets defeated. And hearing what Harun mentioned about the WHO rate of 15%, again, that rate is not absolute. Just because WHO has said it doesn't mean that it is something that we all have to follow. It's a sort of a range that they're talking about. What they have essentially mentioned in that 15% is that at population level, rate of C-section of more than 10% does not really have much impact on the maternal mortality reduction. That is a very loaded statement. So if it's more than 10%, don't think that it is going to reduce the maternal mortality significantly. That's the message what WHO wants to give, and they're not trying to put data, a percentage all over the world that this is something that one has to adhere to. On the Bane side, if you see on the right side of the slide, the overuse of the C-section has not shown benefits and can cause harm, which I mentioned. Higher risk in women with limited resources. So, for example, say in Srinagar, maybe medical college hospital, the resources are very much there, the risk is pretty low. But what about the facilities of FRUs where you do not have the high risk of settings, and there probably the performance, it may be catastrophic to have a C-section there. Coming to the short and long term place, there is a huge number of those. We don't need to really enumerate them. Many may extend for many years. We always talk about the morbidity part. So C-section you have done today, but what does that particular woman goes through for the next 2 to 3 decades? That is something what we have to understand. Now, on the spur of the moment, it is something probably acceptable to the client, acceptable or rather promoted by the health professionals or whatever indications. But down the line, for 3 to 4 decades, this particular woman suffers silently without complaining. That is something which we have to put our minds to. And also it may cause permanent complications, disability or death, particularly in settings that lack the facilities. Next. Now, this particular slide, I'm not going to elaborate too much. Have you skipped one slide? Just see one, if you can put one there. Have you moved back?
One slide back.
Yeah, this is the one. If you see, now this I will not dwell too much. The long-term and short-term risk of Caesarean sections on the left-hand side is mentioned, and all the gynecologists sitting over here would agree with me that likelihood of blood transfusion is very high, thromboembolic phenomena, disease, neonatal respiratory disease. So there are so many complications that can happen as a consequence of the Caesarean section. Doing it is one part of the thing, but keeping those things in mind is another. Complications of anesthesia would be there, risk of asthma and obesity. Also, organ injury is one very common thing we find in our thing. Also, the risk of maternal death associated with C-section is low in high risks, and this I have already mentioned. But if you see, the maternal death following C-section in lower and middle income countries, what Harun was referring to, are 100 times higher than in higher income countries, with up to a third of the babies dying. And that's the data which comes out across from other countries and all other parts of the world. There are conditions over here. I'm not going to go through the condition. I'm going to skip to the next slide, please. So this is the global, next slide, please. So we're giving you a global as well as the India scenario. On the left-hand side, if you see the global scenario, WHO 2018, it says the average C-section rate in the country, in the world is around 18 C-section, 6%. That's something that we can really live with it, and probably it's something that we try to attain. But if you see the range is, the revelation is there in the range. It is from 1.4% to 56.4%. And the countries which are leading is the Caribbean countries and the Latin American countries. And I know for sure because I met one of the professors in a Caribbean country, and they said that they have moved on from stopping C-sections to try to make C-sections safer, because their percentage goes up to 80% over there in their small countries like Caribbean countries like Jamaica or Trinidad and Tobago. They are very, very small and low resource country, yet the Caesarean sections are very, very high. North America, which is the US and the Canada, is 32%. Oceania, which is Australia and the nearby New Zealand, 31%. Europe, 25%. Asia, 19%. And Africa, 7.3%. Thing to see is Europe is only around 25%. That is something most of the progressive countries in the world have been able to bring it to some sort of sense, some sort of normality. Asia, of course, the number is 19.2. It varies across the countries in the region. And if you see the data, as far as NFHS 3 and 4 and 5 data, the ascending steps that you are saying, and ascending very fast. If you see the incremental increase, which is increased from in the birth section, if you see the numbers have gone up to 21.5. In public hospitals, it has remained by and large same. But again, this is a data which gets hidden amongst the states of India. For example, in your state, the public is going up to around 40 plus. But in many states of India, or the EAG states, where the number would be something around 4 to 5. So a law of averages catches up to here. You see 14%. As a country, we have done pretty well in the public sector. But as a country, if you see the private sector numbers, has gone up to 47.4, and that is something quite worrisome for us. And here, the data is actually telling us very loudly that probably the epidemic of C-section has come in, and if we do not act now, it may go out of hand. And that's what we have seen in many of the states of the country. On the right-hand side, the NFHS insights, we are showing that the range is 5.2 in Nagaland to 60% in Telangana, and probably seconded by 1 or 2 states, including the state of Jammu and Kashmir. And out of 36 states, the rise has been there. We have 36 states and UTs. Out of that, 31 have shown a huge gradual increase. Some states have shown very, very steep increases. And Telangana, Andhra, Tamil Nadu, these are the southern states. Again, you have a northeastern state like Sikkim, where the medical services are very, very commercialized, and there Punjab, Kerala, Goa, and of course the state of Jammu Kashmir, they score very high. And it is also, if you see, it's driven by both the public sector as well as the private sector. So we can't blame the private sector. We see that the situation has really gone beyond control in many of the districts and states of our country. Next slide, please. Now this is something what we are seeing in the country. We have around 700 plus districts. There are around 70 districts in the country where the C-section rates are more than 50%. That's huge. And there are about 406 districts, which is more than 15%, what the WHO number was talking about, what Harun was referring to. 84 districts are around 10 to 15%, 101 districts 5 to 10%, and there are 145 districts 0.5%. So as national program managers, we have a real challenge when we talk of the country as a whole. So we have on the one hand the job of trying to curtail the C-section rates in the states and districts where the percentage has gone up too high. And on the other hand, we are talking of promoting C-sections in our difficult states like Uttar Pradesh, Bihar, Madhya Pradesh, Rajasthan, Jharkhand, Chhattisgarh. So you name it, they and Assam, the numbers are very, very low, 4 to 5%. And in this 70 district that we talked about where the cesarean rates are more than 50%, Jammu Kashmir has 8 districts, which is around 12% of the districts which are more than 50%. There are 8 districts which fall in this category. And whether the UT is actually driving that, this is something that for us to see. We have done a little short survey, and here if you see, actually UT comes number 3. After, if you see the pie on the right hand side, after Telangana, Tamil Nadu, and Jammu Kashmir. Now, Telangana has a population of around 4 crores plus. Tamil Nadu has a population of about 9 crores, 7.5 to 8 crores. And Jammu Kashmir would be somewhere around 1 point some crores. So pretty low from that point of view. But in terms of the percentage, if you see, it actually is right there in the top 3. This is something, again, worrisome, and we really, all of us need to act and work together to take a hold of this particular thing that is happening. Next. This is the Jammu Kashmir data. If you see the NFHS, you see the step ladders, how it is climbing very fast. It was, so for example, in public sector it has gone up to 42.7, private sector is 82.1, and that is really ringing the alarm bells for all of us. 82 means, and there are districts, if you see on the right hand side, the red ones that you are seeing, 90% is in Srinagar. So this is something is that probably every single delivery is a C-section. You just can't justify it by saying it they are emergency obstetric care. No. Why do I say that? You see the middle bar graph, table. We are saying in Pulwama, C-section is around 80%, but what is the night C-section? It's only 5%. And this night time period, I'm taking only a very liberal from 8 p.m. to 8 a.m. Coming to Srinagar, 74 is your C-section, 26 is night C-section, Shopia 53, all have been done in the daytime, and Baramulla 58 is the C-section in the morning hours, and the total, and 25% is only night C-section. Now, emergency obstetric care happens round the day. So, a simple medical college coming out, a student coming out of medical college would know that 50% of the deliveries happen during night times. And most of you who have gone through, worked in the labor room, in fact, maximum number of deliveries happen in the night times than in the daytime. And here we are in a situation, we are talking of emergency obstetric care. So if the emergency obstetric care is not taken care of, then you can conclude very strongly that these are all driven elective C-sections. And that is something which all of us as a team have to work towards how do we work to reducing it. And for that, next slide please, we can act at 3 levels. And these are the 3 levels where the issues are arising. One is related to the health professionals. Now when we go to our clinicians, our doctors, they will first say that, okay fine, it's that the client who are wanting it. That is one reason that they say the health professionals will always put it on the client that they want it on a particular day or a particular time. That is the demand of the client. The pregnant women say that doctors influence the physician, and that is quite understandable. position of a doctor is very strong in our society. All said and done, when a doctor says something, the client has no other option but to listen and to follow. So that is the power of medical education doctors in our country even now. So that being the case, if the doctor says, okay, you will have complications, please go for C-section, that poor woman has no other option but to follow suit because she is afraid, her family is afraid, so they actually willingly take that particular decision which supposedly is her decision. Then also, the fear of litigation. Now this is one area why I am saying that these are the things which we see come across along the country when we visit the different states of the country, whether it's Tamil Nadu, Kerala, Andhra, wherever we go. The doctors say that there is huge litigation issues in our country, and in fact there is always a fear that the patients are going to complain against us or hit us. Many of the patients they say कि हमको पिटाई करते हैं कि हम अगर नहीं करें. So that actually is not a very high percentage. It is easier said than done. Maybe 1 to 2% may happen, or not even 1%, so 0.1% something. But that is the excuse we always get that it is the litigation is something that we are worried about, so we want to get it done with. And most important, the last bullet is the comfort of planned data and delivery, especially in private practice. Now, this is a given. There is no second thoughts about it. People may explain that this is not the case, but this is the case. The worrying part is that it's not just the private sector. This particular comfort is actually now seeping into the public sector. So we do not see our public sector doctors. They do not want. I went to Karnataka in one of the best districts and I talked to that gynecologist that why are you not doing cesarean in the night? That Karnataka doctor told me very clearly, so you also have children. I want to finish everything by 5 o'clock. I want to have a peaceful night. So I want to finish it. Either I do it today or I do it tomorrow morning. So that is the way that thinking has gone down in the field, and that is what is really driving this number. Coming to related to childbearing in women and families, the maternal request I talked about, which still continues to be widely debated. One area which is coming up is the fear of labor pain. People nowadays prefer that they do not have labor pain, they can do painless delivery through spinal anesthesia and whatnot. So that is one area. Also fear of negative effects on their sexuality. This again, let me assure you, it's coming up in a very big way, especially in the higher strata of the society, that they do not want to have any damage, so-called damage, and also the issue of sexuality and sexual relationships. That is one area which is driving it, and that's the reason why probably we are having increase of surrogacy. Also, auspicious day I talked about, previous negative experience, and also it's fashionable to have C-sections. That also has come up. It's an aspirational thing which has come up now, is that I had a C-section. And also if I go to Kerala, you know, there is competition. People sell their lands. You probably think that Kerala is a very poor, rich state. Let me tell you, there are poor people there. But because of national prestige, peer pressure, they sell their land just to get their daughter-in-law or daughter having a C-section in a private hospital. They don't even go. In Kerala, of course, you know, 70% of the deliveries happen in the private sector. So the public sector is by and large around 20-25%. Over there, it's just a peer pressure because they had cesarean section on another family, or the sister-in-law had it, so they have to have it. So they sell their lands and property and go for the C-section. So that's a loss you can imagine is that to the whole society which is happening. And also now related to the healthcare system. We know it's higher in private sector. We also know inadequate skills for assisted vaginal delivery. Somehow along the way, the skilled birth attendant training, SBA training has disappeared from our country. We have replaced it Daksha and Dakshata. But the skilled birth attendant, which was the basically gold standard, where really give hands-on training, has disappeared, and we are trying to revive that. Unless and until we have that, our normal deliveries will not increase. Also delay in referral, because emergency sections is the only solution, and poor antenatal quality, because our ANC checkups are also not going up proportionately as with the speed that it has to go. So for example, in Telangana, the antenatal number of antenatal cases they have is around 11 plus in whole term. In our state, many of the states, it's not even 4, and ANC is not being done. So WHO recommendation, next slide, is just what he's talked about. It acts at the women level for the education part, and then for the healthcare professionals, it's very clear. It says that you need a mandatory second opinion for C-section. You cannot just do it on your own. You have to have a mandatory second opinion from another clinician. And one more thing which is doing good is that cesarean section audits, which I'll talk about in one slide. Audits has to be now institutionalized and really monitored very closely. And the last one is the recommendation of the financial strategists is from the program point of view. So how much incentivization you are doing for the Caesarean section deliveries, and we have in many states of our country in terms of giving more money for normal delivery, that will change. Otherwise, coming to the last slide, what did the Government of India do? The Government of India came up with the office memorandum, which we wrote to every Principal Secretary and Mission Director way back in 2015. I think we need to send it once again. It's probably fallen on deaf ear. The mission directors have changed, the principal secretaries have changed, the program officers have changed. So things have moved on. We need to again renew this particular thing. We had also written to FOXI on the WHO statement. So FOXI is also one which really guides the private sector, drives the private sector in our country. They're very powerful. Probably statement from their side will help. Also, central government health schemes, hospitals also, we wrote to them to have a monitoring of this particular C-sections. We came out with a birth companion policy issued in 2016. Laksha, your state is doing well and moving ahead. You probably are going to get 3 more facilities nationally certified. So it's a work in progress. Midwifery initiative is one area where your state is a bit sluggish. We already started our trainings in midwifery in 3 training centers in our country. For short of candidates from the state of Jammu Kashmir, we could not accommodate them. So this is one area we feel that we are going to take a lot of dividend out of this particular initiative to have a leash on this actual rising C-section rates. Also respect to maternity cares and Suman. Suman is one area, although it seems a very abstract sort of a program, but in the end we feel that when it is really overarching all the maternal intervention, Suman is going to pay us the dividend. And we had also built in many incentives in this one. Also we have the Pradhan Mantri Surakshit Matritva Abhiyan, which has now been extended to all states of India. You can take advantage of that. We want to increase the number of ANCs. We are paying money to the ASHA as well as to the beneficiary for the added free ANC checkups, and also we are paying 500 rupees to ASHA if she is able to effect a normal delivery or normal safe delivery with a safe child as well as a safe mother. At the end of 45 days, ASHA gets another 500 rupees. So this is something which he needs to percolate down. It has not happened in your state, although the notification has come around almost 2 months back. Last, about this C-section audit form, just one back. Next. Yeah, okay, fine. That one. Next. So C-section audit, I'll simplify. You won't need to read it. What we are saying is that every C-section that is done in your hospitals has to be audited by the surgeon who has done it on that very particular day. These are actually direction from the Government of India. These C-section audit forms are gone across the country. In case you are not able to do that day, you will have to do it mandatorily by the next day and submit it to the medical officer in charge, which will then be accumulated by the facility. At the end of the 5th of next month, all of those audited forms will be actually appraised by the quality control circle, which is already there under Laksha. They will appraise it, they will study, and they will actually see whether it was required, and then the consolidated statement will go to the state, and the state will then pass it on to the national level. This is the audit. We are taking it very seriously. Many of the states are doing it. Just you can actually extend it to the private sector also. Somebody asked us, can you extend it to the private sector? Yes, very well, you can do that. One thing what we have done in this format is the night Caesarean section we have disaggregated. The next slide, if you see, earlier we were saying 8 a.m. to 8 p.m. Here, if you see, we have segregated further because we saw the field realities. We thought we will divide it even further. So we have one from 9 a.m. to 6 p.m., 6 p.m. to 9 p.m., 9 p.m. to 12 a.m., and then 12 to 6 a.m., and 6 a.m. to 9 a.m. And we know, except for one category, the rest of the places, it is all 0, 0, 0, 0. That is the way we say that, okay, fine, we've done an elective Caesarean section, what was the need for it? So naturally, they need to be pulled up in C-section audits. And also this report that we are talking about, this actually audit forms takes care of the Robson's criteria for the first time. And we have disseminated about 6 months back to every state of India. So the specific recommendation for the state of Jammu Kashmir, if you see, what do you need to do? You can do all the education part, group counseling, state-specific intervention. I'll give an example of Telangana. They are giving more money in the Arogya scheme. Around 3,000 they are giving for C-section, 5,000 for normal delivery. Also in PMJAY, Tamil Nadu has removed C-section from the list of Pradhan Mantri Jan Arogya Yojana. They said you only pay for normal delivery, will not pay for C-section. This is the way that many of the states are going ahead. And the last one is the health system. So C-section audit, midwifery, birth companion policy. These are the areas where we feel that going forward, the state of Jammu Kashmir may look into. So I just made this presentation trying to ignite you all on the areas where we can really have a good discussion over here and come to some sort of, I won't say conclusion in such a short time, at least directions on which we can move ahead. Thank you very much.
Thank you very much, sir. The catch points that I could get from such perspective was these are driven C-sections, it is fashionable, and C-section audit. We have started C-section audit last month in J&K, and so I assure you that we are already going ahead with both medical colleges as well as all medical colleges as well as the peripheral hospitals. So thank you, sir. It was a very elaborated national as well as global review. Now I want to go to my second panelist. He doesn't need any introduction. Sir has remained, Dr. Salim Rahman sir has remained as Director Health Services Kashmir, Jammu, DG Family Welfare, and he is one expert who has been in every field. So sir, I just want to, on the same context, I just want to ask you, sir, what do you think, sir, gave importance to this CS section debate in India? And are CS sections different globally or in India? One. Two, sir, could you justify increasing trend in CS section among today a woman does justify and reasoning in terms of moderation or rural urban perspectives and preference?
Thank you, Arun. At the outset, I must congratulate NHL for holding such a wonderful workshop, and more important, topic they have chosen. This is very relevant, and what position I am taking today. I am sure you had mentioned Caesarean, Boon or Bane. So I am completely for Boon, and I am sure I'll be talking what Dr. Sikdar is a very revered senior as well as very good colleague, and I know him for decades. And I am using same data what Dr. Sikdar has shared during this. And same data I am trying to relate with data per se has no value until it is compared with the previous year or with something which we want to improve upon. So I am comparing all these data and what examples Dr. Sikdar has given. Same example I will be using during my course of this talk, half an hour or so. But I have a clear position today, but this doesn't mean it's a thought process. Such kind of workshop should create an atmosphere where people should say contrary things. And when I say contrary, it doesn't mean that I am trying to say whatever I am saying is right. It's not that. Whenever you have asked me to talk about Boon or Bane, I am talking about Boon. And before coming to this place, few days back, I was for Bane. But today, after going through entire data, I am completely for Boon. This is a point of view, and if not discussed in perspective, purpose of such kind of workshop is of no use. It is a failure then if we don't discuss the other perspective also. Mother never plans a C-section. What they say, they want a healthy baby. They don't want anything else. And now, surprisingly, you will see different agencies in the world, including WHO, saying different things on this account. I can relate the data in I'll be in due course of time. And what you said, you compare with other things, like if I compare top 5 states, Dr. Sikdar has also talked about it. Telangana has 95% of, and just 50% of cesarean section. Andhra has, let me name 5 states, highest number of cesarean section: Andhra, Telangana, J&K, Goa, and Kerala. But can we correlate it with the percentage of institutional deliveries, IMR and NMR? Well, ultimately, what mother wants, your institutional deliveries at all these 5 places more than 95%. Your IMR is lowest at all these places. Your MMR is lowest at all these places. Even I am J&K MMR is at the lowest, around 46. If Ishfaq was studying in the morning, around 2.3 or 2.5 अगर rate लिया जाए, तो what I am trying to say कि आप achieve क्या करना चाहते हैं? हम अचीव करना चाहते हैं कि हमारा मैटरनल मोर्टेलिटी भी कम हो एंड वी आर गेटिंग ड्रास्टिकली डाउन. और साइमल्टेनियसली अगर आप एक्सट्रापोलेट करोगे इसको सी सेक्शन को, तो आपका तो 2030 तक तो और भी क्लोजर हाई जा रहा है. इट इज नॉट वर्किंग डिस्पाइट अवर ऑल स्ट्रेटजीज टिल डेट. इट इज नॉट वर्किंग. सो once you have 99% of institutional delivery, your IMR is coming down. So once you increase the institutional deliveries, it will automatically prefer choice for mother as well as family becomes this. Let me talk about global now. If all the developed nations, let me not talk about Maldives, let me talk about US, Australia, New Zealand, 25% of cesarean section rate. Dr. Siddhar talked about Scandinavian countries. I think we mentioned Denmark or something. They have around 19% of cesarean section. Sweden, they have 20% of cesarean section. And these are the countries जहाँ पे coercion, people can say one thing कि इंडिया में क्या होता है कि मदर जब जाएगी तो उसके पास चॉइस नहीं रहती है, डॉक्टर ने फोर्स किया. ऐसा नहीं है, ऐसा पॉसिबल. यू कैन नॉट फोर्स ए लेडी टू गो फॉर समथिंग, बट लेट मी प्रिज्यूम दैट. बट स्कैंडिनेवियन कंट्री में 50 लाख की पॉपुलेशन में दुनिया की बेस्ट हेल्थ केयर सर्विस अवेलेबल है, फिर भी बेस्ट हेल्थ केयर सर्विस है, लिटिगेंट सोसाइटी है. यू कैन नॉट फोर्स ए लेडी टू गो फॉर स्टिल 20% ऑफ having only 0.07% of the world population. China is 17.7% of the world population. They have 47% of cesarean section. India is 17% population, world population. We have around 21% of cesarean section. But Sweden 0.016%. But still, this is very high. 20%, very high. अगर हम WHO की वो वाली 1985 की स्टैंडर्ड माने तो 10 से 15% से ऊपर तो होना ही नहीं चाहिए. So all these, even 26% यूनाइटेड किंगडम. तो आप इसको कैसे जस्टिफाई करें कि cesarean section is a bane and otherwise it is a troublesome thing. Data doesn't speak it. Doesn't speak like that. So my final point is in my first question, what Dr. Harwood, I don't want to take much time, but अगर ये मुझे डिस्ट्रिक्ट वाइज डेटा एक्सप्लेन करने के लिए भी कहते तो I would do that in next question, but I will compare rural and urban setup also, where I clearly show the data. I am not talking anything. कभी-कभी क्या होता है ना, perception ये होती है, I believe it is like this, it should be like this. I am talking whatever data speaks, or there cannot be any discussion if you are not supported by the data which is available. Thank you, Harun.
Thank you very much, sir. So cesarean section is a boom. That's what comes out of the deliberations by Dr. Salim sir, and we should respect the opinion of worthy panelists, and he has justified also what are the reasons subsequent to his statement. I would again reiterate, please tweet on hashtag MCH Conclave J&K about the topic that is in deliberation right now. And anybody who is the best tweeter is going to get a wonderful tablet. Even our own people can tweet from health department. So this is an open forum. So please start tweeting, and at the end of the panel we're going to announce the winner, as we did in the last panel. So thank you, sir, very much. Now we will go to the third panelist. She again doesn't need any introduction. Dr. Rizwana Habib is a professor in HOD. Government LD Hospital, Srinagar, very important hospital. From last 5 months, we are very happy that not a single death has happened. Although something went well from the last 2 months and some had. But this is the sole maternity hospital in Kashmir Valley, which is a huge population. And they are the sole hospital where most of the referrals take place. So it is their hard work, their dignity, how they have been catering to such a huge population. Ma'am, my first question for you would be, what are the reasons for increasing rate of cesarean sections, especially in the valley? What kind of patients do you see? And what is it that, why can't we go for normal deliveries in the tertiary hospitals? And what is your perspective on this? Ma'am.
This is really a very stimulating discussion, and I'm happy to be here. And I thank NHM personnel, all of you for that. So you were saying that we didn't have any deaths, and if there are no deaths, the credit doesn't go to us. The credit goes to the field people, because we are a tertiary care center, and if we get patients in time, we can save them. If we don't get them in time, we cannot save them. So the credit, it doesn't go to us. I always say that. It goes to the people who send them to us in time. And I'm thankful to them that they are now very vigilant, and they do send. Recently we had few deaths, and we are going, in maternal mortality, maybe they will be discussed. They were due to the reason they were not sending them, and just like my colleague said, Dr. Masuma, that it was because of the transportation problem. So that is besides the point. The point this time is about Caesarean sections. So this being, I will tell you Caesarean sections from a perspective of a Kashmiri, because there is a regional difference everywhere. So first I will say why Caesareans are being done in my hospital, and why not more of normal deliveries. It's not like that. We have 60% Caesarean rate, and we have a 40% of normal delivery rate. But we have to understand that we get more than 50% patients who are referred to us, either at the time of in emergencies or beforehand, who are high-risk patients. Like they are placenta accreta, placenta previa, they are fulminant preeclampsia, and malpresentations, and so on and so forth. So obviously our rate should be 100% because of that, because we are a tertiary care referral hospital. We are not supposed to cater to the normal patients, ideally. But this being a hilly terrain, and our services are not so good as of yet, but our government is working on that, and hopefully in near future we will not get so many cases, and hopefully we will only cater to the high-risk patients and do some gynae part also, because of this we are not able to do much of gynae. So now that is for the hospital. Now what happens in a Kashmiri society? What I have found, we have late age of marriages now. Girls want to complete their education, they want to have a career, and then they want to start the family. And once they are more than 30, if they become elderly primary gravidas, they become high risk, and because of that there is more chances of endometriosis, PCOS, they are diabetic, and all that. They are self-fertile, and usually they conceive after some help, maybe induction protocols, or sometimes they may need IUIs, they may need IVF. And once such a patient comes to us who already has started her pregnancy late, we cannot take any risk with her, neither can she. So that becomes one of the major causes of Caesarean section. Another thing is, and I think my colleagues will agree, that as soon as a patient becomes pregnant, the mother comes to us and asks us to write bed rest. I don't know why that is happening. I think most of you agree with me that that is the first thing they will ask. She has to do a lot of work at her in-laws, please write bed rest. And with that bed rest, all the doctors, some of the doctors are then, they sort of have to write it, otherwise they'll lose the patients and all that. I'm not going to that. So they rest all the 9 months instead of working normally. And because of that, they get macrosonic babies. And we also have a very high rate of GDM here. So once we have microsonic baby and it becomes a high-risk patient, that is another cause, and there is no other, we don't have any other way. Then another thing is, as Dr. Sikdar also says, peer pressure is there. That also we have seen in this part also. People do sometimes sell some gold or something and get cesarean done in a private nursing home. And in a private nursing home in the Kashmir, I would like to say that you can only have, you say that it's a 90% rate. The 90% rate is because they are just nursing homes. They are not maternity homes. There is no facility for maternity. As we know, they have facility for a nursing home, but not for a maternity home. They should have a full-fledged gynecologist working 24/7 then. What happens that a doctor, a gynecologist, has to do a cesarean section, whatever the reason, whether it is whether it is really to be done or it is on demand or whatever, she goes along with the anesthetist and along with the pediatrician, and cesarean is done, and that's that. So that is why the nursing homes can't have normal deliveries. Especially in Kashmir, we don't have a hospital like Apollo and other hospitals here. Then there is another thing, these social factors like there is fear of complications, both for the doctor and the patient. Neither the doctor wants any complication, nor the patient wants any, patient or attendant wants any complication. Dr. Sikdar sir did say that it is, patient says that the doctor has said and doctor says that patient has said, but in our part, it is the patients who are very much persistent. They get, they have all sorts of pressures on us, all sorts of influences they try on us. That I can tell you of a case, recently we had a patient who was admitted in the morning at 7. She already was diagnosed with IUD. She came with IUD. So obviously we counseled her for vaginal delivery. At 10 in night, somebody is calling me and there's a live streaming on Facebook that the doctor has killed the baby and they are not now doing the Caesarean section. And there's a thing they call here motbah, that she will now die. So what to do? All the staff was in tears. They will be live stream that they had refused the section. So there are some pressures which we can't deny. Then other things are, what happens, we have a Caesarean here. And LG hospital being the main tertiary care hospital, I am so happy and so glad to say that most of the people trust us. And most of the people from the Caesarean come to the city to get antenatal checkups here. As I said, some are referred in emergency, but most of the patients of their own get LD card. This is everybody must be knowing what is LD card. Everybody wants LD card. It's an antenatal card which every pregnant female in Valley wants to have. So what happens is when they come here, they rent a room. Then they are after our life to get admitted. And once we admit a patient, obviously we will then induce them. Somehow, I don't know whether there's a lack of communication, maybe our juniors or maybe there is some fault in seniors also, that we may not be able to counsel them. That is why after failed induction, after some time, even after 2-3 hours only, we start induction and they start pressurizing us to get LSCS. And they get all sorts of influence. And here I want to say even politicians come and influence us. From secretariat, I'll be very bold in saying that. Even in secretariat, I get a call, madam, patient hai, iska Caesarean karo. And my principal, she tells me that 50% cases I don't tell you. So these are some of the cases where you have to see. Now, as Dr. Salimur Rahman sir was saying that it is a Boon and a Bane, I would like to say even in Lancet, it has, we see that the rate has tripled, and it is not only in Kashmir or J&K or India, it is world over. So let us not be defensive. Why should we be defensive? That it is only, it has increased here only. What he said, and he is right in saying that we have decreased maternal mortality because of this. Timely Caesarean sections in permanent eclampsia, pre-eclampsia, this APH, and transverse lives, and any labor which we presume will go into obstetrical labor and do it beforehand. We do save lives that time. So it's not that only this. I think it's enough.
Thank you very much, ma'am. It was a very wonderfully put the right perspective at the right place. And she has tried to give a very honest picture of the LD hospital and the modus operandi that they use. And ma'am, I know how difficult it is to be the HOD guy of such a big institution where you have so much of pressure, as you said. And still, as I said, the mortality rate is so less, so low at LD. Although we are still in the process of deliberations, whether it's a boon or a ban. There are some people who are like it is a boon, and some there were. Now I will go to my fourth panelist, ma'am Anita Gupta is a professor and the counterpart of Dr. Rizwana at GMC Jammu. Ma'am, I would really again want to take a Jammu perspective. As Rizwana ma'am said that in Kashmir there are certain reasons, there are certain obligations, and I will not go to the nuances of it. What do you think are the reasons that we have such huge cesarean rates at Jammu, and what are the problems that you face while trying to motivate people not to go for cesareans?
afternoon, everyone. I am neither against nor for, but I would certainly like to put few lines to tell you why this is against Section 8 is a lahar. Actually, the preparations should start right from the antenatal period, and I mean it that if the mother is not anemic, the fetus inside, if it is a female, it will not be anemic, and no, the mother of so many problems is anemic. Number 2, sensitization right from the college. We have to tell our girls that they should be able to handle pressure, they should be taught about an active lifestyle, and in the school we should prevent anemia, because anemia per se leads to so many diseases. Have you ever seen any girl visiting the doctor and asking the doctor, "Doctor, I have to plan my family"? No. Even a simple car, once it comes out of the factory, there is a return. Test it, okay. Not a single girl is given a certificate that she is fit to produce a life, and science has not been able to produce even a bacteria. Okay. Number 3, there is no provision of sir, in our setup, whether it is Kashmir or Jammu, for any antenatal classes. And so many well-read girls, they do come to us and ask us, "Ma'am, can we do yoga? Ma'am, can we do exercise?" Right? And I don't have any answer. Number 2, we don't have any nutritionists in our institutions, because, as ma'am said, they are on the bed as if they have climbed the Mount Everest by becoming pregnant. So they just sit and eat. And basically, I am telling you, it is our bad lifestyle and half education. And I mean it, half education. In our Jammu and Kashmir, our girls are half educated. Well, in Bombay or in Delhi, you tell a girl that you need to have a cesarean section. She will ask you 5 questions. Why? Why can't I have a vaginal delivery? And here, our girls straightway tell us, "Ma'am, mujhe to first visit, you have to write on the card, she wants a cesarean section." You know that? We are in the first pressure. The first thing we have to write on the card is, she wants a cesarean section. And you know, nowadays, there is lack of trust in the family. We need to build that trust. Why it is so that 50 years back, you can just have this observation that our fathers, even my father, had a second marriage, and you should see this observation. Every 3rd male would have a second marriage. Why? Because there were maternal deaths. Nowadays, you have cesarean section, and we have decreased that maternal mortality. Now, family bonding is must. Otherwise, mother-in-law was a boss, and she would never let the daughter-in-law visit the doctor, or with a complaint that she has failed. She would tell her, "You just be relaxed," and once the laboring woman comes to labor room, she was halfway through. And nowadays, with one pain, they are in the hospital. And what should the doctor tell? "I will not admit you." You can't say that. You know, I will give an example. Cord around neck, and it is written in our books, 1% risk, just tell the patient. And 99% you tell vaginal delivery. The same statement, I tell the patient, 1% risk, and even then at that risk, I can do a cesarean section. 99% you will have a vaginal delivery. What was the answer? "Madam, this is my child. You are nobody to take the risk." Okay. Lifestyle changes. In the college, we should tell our students that you should have an active lifestyle and a balanced nutrition. Then, in order to decrease the cesarean section, I am neither against nor for, but you cannot beat the nature. Nature is supreme. That means if nature had made a vaginal delivery, it is the best. So we should have a group practice. I was talking to Dr. Salim that you should not post consultants at the periphery PSC level. Post all of them in district level, so they have a confidence. Because, you know, we are really scared of PPH. We are really scared of PPH. We lost our colleague by hanging just because the patient had PPH. Next, yes, we should also take some responsibility in the institution that we have to teach them the art of instrumental delivery, where we are lacking. Because Caesarean section is on the high and our PGs are not able to, they are not expert in handling forceps delivery, venous delivery. Then, of course, from Government of India, the Caesarean section audit, which has come, is a good thing. That is really going to stop the unnecessarily done Caesarean sections. But, sir, I would say that we have also given some extended indication ourselves for Caesarean section, like HIV, like HBS, and then certain indications which were not there once we were undergraduates, like polystasis of pregnancy was not an entity 25 years back. No, it is an entity. Then card around neck, as you yourself say, sir, with technology, there is plus and minus. So, with increasing rate of Caesarean section, we also have some advantages and some disadvantages. We should not forget, why should the Caesarean section came? The first Caesarean section was done. Why? Why was it done? Because it was done because it was a necessity. So that means it was good. And I would end my this discussion that if we want to really take care of the incidence, increase in the incidence, we should have a group practice and we should have a healthy lifestyle and good training. Thank you.
Thank you very much, ma'am, for a very wonderful perspective and for very honest remarks. I would again want to reiterate that please go for hashtag MCH Conclave J&K, send your tweets, and I would reiterate that this won't be a winner at the end of this session. Thank you, ma'am. Once again, we had the tertiary care perspective, we had the national perspective, we had perspective from a very public health background. Now I really want to go to my final member here. Dr. Priyanka Bhagat is a consultant gynecologist at District Hospital, Poonch. And ma'am, I want to really know the ground level perspective. What do you think, ma'am, in the field needs to be done, either to stop or lessen the Caesarean sections, and honestly to promote the natural deliveries? Ma'am, what needs to be done, and what do you think are your limitations? Please be very frank. Thank you, ma'am.
Good afternoon. Am I audible?
Can we have a hand mic to?
Good afternoon, everyone. I'm Dr. Priyanka Bhagat, consultant gynecologist DH Poonch. First of all, I congratulate Yasin sir for such an event, and thank you for inviting me and giving me this opportunity to tell you all about the problems we face at the peripheral level. So now, sir, regarding your question, as being gynecologists, we all know the limitations of Caesarean sections and what are its complications and what are its effects on mother and the child. But like injury to the organs, thrombophlebitis, thromboembolism, increased risk of PPH, increased rate of blood transfusions and blood loss, and infective Boon, endometriitis, all that. But despite of that, we working in the periphery, we are taking, I'll tell you why we are doing more Caesarean sections. Like, increasing number of repeat Caesarean section is the one indication we are facing, and we are doing the Caesarean for that. Because I am working at DH Poonch, so the sub-peripheries like SDH, Mandi, Mender, they are not well equipped earlier. So we get the referral from that side. So we have to do the Caesareans, and from now I thank Dr. Salim sir. They have made functional the SDH student code, SDH Mender and Mandi. So we will try it will lessen our the workload. Next is frequent diagnosis of the fetal distress on electronic fetal heart rate monitoring. When the fetal distress is diagnosed, so doctor भी panic हो गया, patient भी panic हो गया, so we will resort for the Caesarean section. increased use of Caesarean for breech presentation, frequent resort to elective LSCS in high-risk situations like elderly primary gravidae, as my senior Dr. Rizwana and Ma'am Dr. Amita has already quoted, IVF cases, maternal diabetes, PIH with placental insufficiency, IUTR of the fetus, postdatism, previous unexplained fetal losses, CPD, malpresentation, and one new, as Dr. Amita has already quoted, to prevent the vertical transmission of maternal infection to fetus as in HIV, infection and genital herpes. Now, for the better maternal and fetal prognosis in cases of APH in cesareans, to avoid the difficult manipulative and instrumental vaginal deliveries which carry high risk of morbidity, there is also an increasing trend. Now, in Poonch, I am facing the multi-gravida patients with previous normal vaginal deliveries. They are saying cesarean section with tubectomy ligation. कि एक ही बार में ऑपरेशन भी कर दो और साथ में बच्चा भी बंद कर दो. We suggest them कि कोई बात नहीं, you go for the normal vaginal delivery and then we will opt for the tubectomy ligation. They say no, एक ही बार में काम हो जाए, cesarean में कर दो और बच्चे भी बंद कर दो. And rightly said by Dr. Rizwana, IUD is becoming a very great indication or a common indication. One patient I have also suffered very badly. A patient एक आया IUD करके, and that was 32 weeks. I kept her for the normal vaginal delivery. So she said कि सुबह से बैठे हुए हैं, infection हो जाएगा, जहर फैल जाएगा. So I refused कि नहीं, you by the evening you will be delivered normally. They said no, please refer us. So we'll go to the higher institution and like that. And now some patient conveniences are also there, that like the rapid socio-economic changes that ma'am has already said. You know, ladies, there is a misconception that LSAS is safer for the babies, fear of labor pains, concern about the genital modifications, lower tolerance to any complication. Moreover, nowadays, there is a new indication that has developed on the basis of the horoscope and communities, that is the Muhurat Caesarean. And people are paying so much for that. And some doctor conveniences also, as already said, like practitioners nowadays are adopting a defensive medicine to have a better outcome to avoid the medical legal litigations.
Thank you very much, Dr. Priyanka, for a very great field perspective which we really need. This is such a topic that the time, we are already exceeding the time, but before I conclude, I want to have one minute final remark from every member. Dr. Siddhar sir, your 1 minute remark please, because we already exceeded time.
So thank you, and I don't think this particular time period allotted is good enough for a detailed discussion of such a complex and vexed issue. Just one liner, first of all, I'll say that we can solve a problem if we can recognize it. If you say it's not a problem, fine it is, let's all go home. But if you think that it is a problem, then of course all of us as scientists and people of science should really take action in this regard. And at what cost? So maternal mortality reduction for the state of Jammu and Kashmir, if whatever is coming, it does not come. You know, if I can discount the data which is given by SRS for all other states, so for the number of deaths that you have, it comes to around 60-70, but we all know that it is grossly underreported. First of all, what is happening in the pathlang areas, in accessible areas, in the nomadic population, we do not know. How many of us know maternal death definition? And the narrative about penalization of maternal death has not changed. Although we are paying money now to report maternal death, but the fact of the matter is that even now, that particular narrative is there, that if you really report a maternal death, maybe you will be penalized. So the point of the discussion is that other countries, forget about other countries, Scandinavian countries, even after all the advancement, they still have 19%. I would say it's still good. So 19, WHO says 10 to 15, it can go up to 20. So if the referral increases, go up to another 5%. So it's like that. And what about the high-risk pregnancies? 10 to 15% high-risk pregnancies. So we are saying that they will need cesarean section as it is, they will definitely need it. And your state is reporting 15% or 14% HRB. So you have to titrate against that. And then comes the bureaucratic political pressure. So you as people of science, if you cannot stand your ground based on standard operating procedures, then you have to suffer the consequences. And what happens to that poor baby being born, which is early childhood development is stunted, the mother is going through the morbidity for just one moment of glory. So things cannot be solved in just this one thing, and the conditions that you narrated, so many of them, all of them add up to only 10 to 15%. Your textbooks which you are quoting say that. Your experiences which you are saying say that. Maharashtra has got an IMR of 16, and they have a maternal mortality ratio around 38. How have they done it at a Caesarean section rate of 20%? So point is that you have to look up to better states of our country. So we should not be seen as a repository of all knowledge. And sitting over here as a representative of the Government of India, my duty is to open up your eyes to the rest of the country to which we belong, how other states, progressive states, have done by implementing protocols. Caesarean section audit is one such, but what about the other ones? And if it is so necessary, why do you show me 0% night C-section? That's my final question to you. In emergency obstetric care, you are talking about why 0% night C-section. That's about all. Thank you.
Thank you very much, sir. Caesarean section is done. Here comes the verdict from Dr. Siddha sir. Now, Dr. Salim Rahman, sir, your final words.
I started my presentation with that. I said there are different kind of distractions from different organizations. I was directly talking about WHO. WHO in 1985 said there is no justification for any region to have Caesarean section rates higher than 10 to 15%. And तब से लेके आज तक हमने इसको छाती से लगा दिया। 10 से जहां भी कोट करना था, I have given at least 1 lakh times this example कि 15% पर नहीं जा सकते हो क्योंकि WHO ने ऐसा बोला है। लेकिन WHO ही 2018 में नया स्टेटमेंट दिया। Let me quote it. The time has come to put the debate about the preferable rate of Caesarean section on hold. Let us start to collect data uniformly so that in the near future we will be able to move our focus from Caesarean section rates and population to monitoring and discussing Caesarean section rates and outcomes in each group of Robson classification. Robson classification is internationally accepted classification जिसमें सारी डिजीज को 10 इंडिकेटर्स में बांटा गया है और हर एक इंडिकेटर में अब आपको प्रॉस एंड कॉन्स देखने हैं, फिर एसेस करना है कि परसेंटेज ऑफ Caesarean section क्या होना चाहिए. तो अगेन my point here is again I am not trying to tell the audience that I am right. It is only a thought process which needs to be assessed and generated, discussed across the. And we have people and we cannot be myopic. We cannot stick to 10 to 15%. We cannot stick to the. When we talk of advantage and disadvantage, Caesarean section has disadvantage. But once I was studying very recently, there are much more disadvantages with the normal delivery. If I try to make a list for both the things, the list goes higher, balance more towards Caesarean section. And that is very clearly what I try to see. So, what is the best way forward? This workshop, here we have so much learned people. Dr. Siddha is there, huge experience and master in the field. Dr. Arun is here. I was seeing him in the morning.
He's here.
Look, he is a pioneer of GSS. People might not be knowing जब ये NICU वगैरह का basic concept शुरू हुआ था country में way back 20 years back, 15. He is the person. Such kind of people, a team should be constituted. They should work is India centric. Because if globally you see it's a global trend, it's a global trend and people are जहाँ पे जब global trend की बात करें, it's a very detailed region. Rural urban बात करेंगे तो आप पुलवामा में 60% है और श्रीनगर में 56% है. तो बाड़ीपुरा में भी 50% है. So that's a rural area, but still people have preference. Ultimately, अगर आप समझें, Rambagh has 20%. Why? Because there are only 2 health institutions जहाँ पे Caesarean section होता है. बाकी सारा एरिया वहाँ पे forced normal लेबर. लोगों को चुनी अपने चॉइस की वो Caesarean section की तरफ. तो मेरा यही है कि एक बेस्ट कमेटी हो. डॉक्टर यासीन साहब यहाँ पे है, यहाँ पर जो आपके रिपोर्टर होगा जो भी यहाँ से बना रहा होगा मिनट्स, you should put it that डॉक्टर ने जो रिकमेंडेशन दिया है कि वहाँ पे ये डिस्कस करें. क्योंकि ऐसे नहीं चलेगा ना कि we believe 15% बाद में 25-35 साल के बाद बोलना कि अब आप रॉब्सन क्लासिफिकेशन फॉलो. What was they doing for last 25 years? जो अपने साथी से लगा के रखते हैं. तो मेरा यही है कि एक रिकमेंडेशन बने, इससे रिकमेंडेशन बन के proper thought process involved, which I started with, and I'm sure will come a better document and better strategy to combat this thing, whether it is good or bad.
Thank you, sir. So it's a point invited from the Salim sir. Dr. Iswana, ma'am, just one minute, quickly, your last remarks.
As a clinician, I would like to say that we should decrease the rate of caesarean sections, and that has to be decreased at the grassroots level. If we decrease the rate of first caesarean section in a primary, we will be able to achieve our goals. So we have to do that, and how to do that? We have to have print and electronic media, then counseling with the couples once she's. And I would like to say in my society, counseling the mother, because it is a mother who comes and says that my daughter is not going to bear the pain. So we have to counsel the family. That is very important. Then we have to, as much as possible, admit patient during labor. Because once we admit her earlier, then it really results in caesarean sections. Then in low-risk patients, obviously not in high-risk patients. So, and once we are going for induction or augmentation, we have to counsel them about the time. Because if they know that it's going to be a road journey, so it's like a road journey. Labor is like a road journey, while a caesarean is like going by a plane. So we have to make that road journey very comfortable for her. We have to have respectful maternity services for her. With that, I thank you.
Thank you, ma'am. So we need to have good communication strategy. We need to have good behavior change communication. Is the final word from Zwana ma'am. Amita ma'am, your final remarks.
I have only 3 points. Number 1, I take it on myself, good training of the doctors. Whenever you declare a patient for caesarean section, first ask yourself, is this the only option? Number 2, teach your daughters how to handle the stress. And number 3, good laws in favor of doctors.
Thank you, ma'am. Dr. Priyanka Bhagat, final remarks.
Same as in periphery, we have to educational interventions that engage the women actively in planning for the birth, such as childbirth preparation programs, relaxation programs, psychological supports for those with the fear of pain or anxiety, and especially the preparation of labor rooms. Labor rooms should be so comfortable and so that the ladies who are going to deliver, they feel safe and comfortable. As said, respectful mother care courses, Dakshata and skill work courses, and the use of evidence-based clinical guidelines like performing the regular caesarean operates in the health facility, as we have already started in our district Boon, and requirement of a second medical opinion for this caesarean section decision in setting where there is a possible government HDUs, development of HDUs, maternal ICUs, and blood transfusion units.
Thank you, ma'am. We already started the section audit. I'm quickly opening the floor for quick three. Just, I know it's a very wonderful topic and a lot of people want to pose the questions. So one by one, the floor is open. Yes, ma'am. Yeah, Priyanka. Yes, ma'am. Hand mic. मैम को हैंड माइक दीजिए. 2-3 लोग उधर रहिए. Dr. Padmini ma'am is Deputy Commissioner, Maternal Health Government of India. So if she's posing a question, it's a wonderful thing.
Yeah, so thank you so very much, all the eminent panelists. It was quite a good, interesting discussion. And I totally agree with what Dr. Singhal sir said. Unless we realize a problem, we cannot find out a solution. So now, I overheard somebody said that there are new indications for caesarean section like HIV positive pregnant women and hepatitis. Right? Madam, we at the national level, we do not recommend this. And
it is in the books.
No,
it is in the books.
Not in the national guidelines, ma'am. Unless there is an obstetric indication, we do not recommend caesarean section for an infection.
Ma'am, there are previously 2 indications, absolute and relative. And now there is a third one, extended.
Okay. So, again I am repeating, from the national level we are not recommending, because any patient, if she is harboring any infection like HIV and HBs antigen, like the hepatitis, there are chances of spillage, which leads to further infection of the healthcare person.
No, not healthcare, ma'am.
In fact, of course, baby also and the healthcare worker also who is providing her the services. So, as per the national guidelines, we are not recommending them. And other thing is, madam, as she rightly said that, we are receiving high-risk pregnancies in such a stage at the tertiary care facilities that the patient receives, she has to be provided cesarean section. Now the point is that if the patient, अगर हमारे पास उस stage में आ रही है कि हमें उसे सीधा cesarean करना पड़ रहा है, तो हमारी जो services हैं, it really raises a question on the kind of services from the time of inception, from the time of conception of the women to the time that she ultimately delivers. Overall health system के ऊपर it raises a big question. Thank you.
Thank you. Masuma is on her back. Yes, yes, ma'am.
There is a big gap between the antenatal care that we provide and the primary care that is happening in this part of the country. You have to understand that the antenatal care has been given in the hands of ASHAs here, and that patients what we get is referrals. They must have visited the ASHAs at least 100 times, but not even once their blood group is recorded, not even once their hemoglobin is checked. So when you extrapolate the data that you have an 84 or 90% of an antenatal care, that is something which is wrong. And that is where the basic crux lies. See that the highest patient that we get is that there are those neglected patients who once they reach the secondary care center are beyond their management and they land up with us. Number two is that when we say that decreasing the cesarean section rate, yes. Is it achievable? Yes, but then we have to have facilities for achieving that. It's only 10% of cesarean sections that can be decreased. If we have a data which says that 46% is the cesarean section rate in Kashmir overall, the decrease can be only 10%. And that can only happen when your primary centers are functional 24/7 with expert facilities available and the plant right facilities available at those levels.
We have Dr. Para and then we will have Dr. Poonam Fine. Dr. Shikpal.
It was a very impressive and scintillating debate on a very important topic. But I would like to take this August gathering back to 16th of October 1846, when the first anesthesia was given world over in US. And it was because of that anesthesia that the pain in the surgery was annulled and averted. Let me give one final conclusion on this event, that until and unless we don't introduce labor analgesia in our day-to-day practice, the cesarean rate will not come down. It's high time that we introduce labor analgesia into our regular practice in at least leading institutions. Slowly and slowly, the trend will get reversed. Thank you.
Congratulations to this first ever MCH Conclave by Jammu and Kashmir. I'm Dr. Shanta Kumari, President of FOXI, 38,000 strong body of OB-GYNs. Today, this discussion actually needs a whole day. But what I would put is, we are not going to say whether it's going to be a debate, whether it's going to be a Boon or Bane. See, an expert like Siddhar sir, who has the ability to debate and he can actually hit you hollow. With his oratorial skills, you will never be able to beat what he's saying. But the ideal point is, neither do I agree with Siddhar sir, our 10 to 15% of WHO, which was reported way back in 80s, or neither will I 100% say my gynecologists are also okay when it is 90% of cesareans. We have to look at it overall. What is it that when we are looking at a cesarean section? Are we looking at maternal health? We're looking at the neonatal outcome, but at the same time, the woman's health also is important. So we have to look. I'm not only a president of FOXI, I am the treasurer of FIGO. So I'm at the global level. So we interact with the WHO, we interact with the UN, UNFPA and all the organizations. And as rightly put by my colleague, though he's not a gynecologist, WHO now states that it's not the optimal rate which is important. You have to look at the holistic outcome. But that again doesn't say that I'm going to support something where a facility will have 90 to 100%. See, I am from Telangana, very proud to be Telanganite, but I have to bend my head down when I see 90 to 100%. So when I go to my bureaucrats and my administrative, I have to actually fight them out to support my colleagues, and when I come back, I have to shout at them, and at the same time take the brickbats from them that you are supporting the government and not us. So I think we have to look at it very holistically and see how we have to approach. It's not only the rate per se, The most important is the primary C-section, and the other most important, Robson criteria. Robson is a very dear friend of mine who's coming to Hyderabad on the July 15, 16, 17. You look at Robson criteria to see the way you practice, the way you can look at your data, where you can say, okay, this primary, I can look at it where I can reduce the C-section. Robson criteria, by just following it, your C-section rates won't go down. It will reflect the way you practice, and you relook at your practice, relook at your indications, and automatically I think that would be achieved. And I think we should leave this blame game of either the bureaucracy or the healthcare personnel and the doctors at the other. We should not be at loggerheads. We should be working together holistically to see how we have to approach. Because it is not only the health of the woman, it's the health of the family, it's the health of the country, everyone. So I think this is very important. So the discussion, because what happens is in the social media, you see some of the Twitter, which replies have come. They're not very good for the doctor colleagues of mine. I wouldn't be happy to hear somebody tell that I have been cut open. No, the doctor has cut open the abdomen. I wouldn't like to listen to that sort of a statement. At the same time, looking at the rates, also we have to see how we have to approach. So this is my humble request is, we need to have a dialogue, not a debate, and look at it holistically. I'm very sure that we'll be able to come to a consensus. And Robson himself is a very dear friend of mine. That's why he was saying, I need to talk. He's having a meeting with our ministry. But I think we need to have one such discussion, and then we are on the right track. But the way we put it, it's not going to be who is going to be a good orator or who is going to defend himself. It's not going to be that. Thank you.
Thank you, ma'am. We'll have this final. It's such a vibrant topic that there's no end to this. One final question from Dr. Poonam Sethi.
First of all, I congratulate NSM department for arranging this MCH Conclave, which was very good, and we were able to interact with the people of the so much repute. So my question, it's not question, it is my opinion is that that WHO has taken into account 10 to 15% mortality rate, but they have not taken into account the morbidity. So this number, this percentage should be more, because they have not taken into account morbidity for both for the maternal and the child morbidity. As for the maternal, pelvic organ prolapse, sphincter injury, sexual dysfunction, fistula, and for the baby, hypoxic baby. And another thing very important is, as all of you have said, that in the tertiary hospital, there is referral, that is why cesarean sections are more. But we have to consider that at the PAC level, at the grassroots level, if a primary patient is given due trial of the labor and then delivered by vaginally, this rate will decrease. But the problem is, we have got only one gynecologist and one anesthetist at the PSC level. Even in some district hospitals also there is only one. How can that person will work 24/7 whole day because for giving them vaginal delivery? You have to monitor the patient and then have to decide this. How one person will work long time 24/7 for whole month or for whole year? It is not possible. Then he or she has to bend to the cesarean section in the morning. So there is a problem. As in our state, I want to say, I should not say at this level, but as in our state, most of the medical officers are not joining the government job. Reason for this is, there is ban on, if the medical officer joins our government service, there is ban of 5 years if he or she cannot go to the PG or the senior residency, if he or she joins the government service. Just tell me how a doctor will join the service. Most of the doctors, PSC list is there, they are not joining. No. Not the consultant, not the medical officers. Then how will our peripheral services will improve? So basic level approach is wrong in Tamil, because at the basic level, unless we will do the cesarean, number of gynecologists and anesthetists are not there, we will not improve our policy of banning the medical officer to not, they cannot apply for the PG services. They cannot apply for the senior residency if they have joined the government service. Who will come? I don't think in last 2-3 years list is there and nobody is joining. So how will you improve this topic of
Thank you very much, ma'am. So finally we come to this conclusion. we don't exactly know whether increased cesarean section is a boon or a bane. But yes, there are certain protocols, there are certain SOPs, there are certain guidelines that need to be adhered to, that need to be implemented in toto, both internationally as well as in the state. We have started with cesarean section audit as I've written a small article just recently, and I quoted, let's catch them young. So yes, we need to have that communication strategy in place. We need to start with very first ANC checkup and tell them what are the merits and demerits of cesarean section vis-a-vis normal delivery. I thank Dr. Sikdar sir, Dr. Salim Rahman, Dr. Rizwana ma'am, Dr. Anita ma'am, and my last consultant, Ma'am Anita. God bless you all. Thank you very much. It was a wonderful debate. Thank you. Take care.
So please be seated. We thank our worthy panelists for this enlightening session. It was indeed valuable. To sum it up, we have the winner of our tweet concept. He is Vishal Kataria. He has tweeted that a mother never plans a C-section. She only plans to deliver a healthy baby, no matter what it took. So sir, we'll give you your tab soon. So now I request our MD NHM for the facilitation. Thank you so much, our panelists, our moderator, and sir. We'll just start off our next session in next 5 minutes. The next session is on neonatal stabilization. The moderator is Dr. Yunus Mushtaq, and the introducer is Dr. Yunus, and the moderator is Dr. Anil Manas.
Good afternoon. I am glad